Right, guys. So I am going to be giving the first talk in this series. As Nicole mentioned, we'll have several talks and we'll go over what those topics are, but I'm going to do sort of a broad overview of what is DBS, that's deep brain stimulation. We'll focus a lot on Parkinson's disease and essential tremor, and we'll mention a little bit about dystonia as well. And I'll talk a little bit about some of the other surgical procedures that are out there that you may have come across that were used in the past, just so everyone is aware of what our options are out there. In terms of disclosures, mostly these are related to research funding for me, and then our institution has received educational grants and fellowship training from some of the companies that provide the DBS devices. So like I said, today I'm doing a little overview of what DBS is and a few other topics. And we'll touch on each of these individual topics a tiny bit today, but each of these webinars will delve into the topics in a lot more detail. So Dr. Baumgartner is going to go over, who should be considering DBS, whether they're candidates for it or not. Dr. Ojiman is our neurosurgeon, so I'll talk a lot more about the surgical part of things. Dr. Thompson is going to talk about something called LFP. Those are local field potentials. He'll talk about what those actually are, why they're relevant, how we use them when we're talking about and undergoing DBS. And then Dr. Drew Kern and Mari Kelly are going to talk about what's next in the world of DBS for us. And then, like I said, a little overview of today's talk. So we're going to focus on DBS specifically for movement disorders. It is available as an option for other disorders, such as seizures and obsessive compulsive disorders, but we're going to focus on movement disorders specifically. We'll talk very briefly about what we mean when we say advanced Parkinson's disease in this setting, and what we mean when we talk about essential tremor and dystonia. What advanced therapies actually are. You'll hear us use that term a lot, and so just a little overview of what all we're talking about, and those include things that we call lesional therapies, and then we'll spend most of the time talking a little bit more about deep brain stimulation, DBS itself. So when we talk about advanced Parkinson's disease, it's important to know that there's not sort of a definition that everyone agrees upon for advanced Parkinson's disease, but generally most people are roughly on the same page when we're talking about it. In the context of advanced therapies, we're talking about a stage in the disease where your symptoms aren't controlled with medication alone. And that's the same for essential tremor and the same for dystonia. When we're talking about advanced therapies, it's that point in the disease, and that point can be different for different people. But it's when those medications really are not providing enough benefit on a day-to-day basis. So in Parkinson's disease, that might mean having a lot of on time and off time. And what that really means is on medication and off medication. And so you take your meds, you can feel it working, it's helping. And then before your next dose, you can tell the medication, particularly levodopa, is wearing off. And so you have that sense of on and off. It might be when you develop dyskinesia, and those are those extra movements or the twisty, writhing movements that usually come out when the meds are working, though not always. And then also refractory tremor. And so that is more, and what I mean by that is a tremor that either never responded to medication in Parkinson's disease, or it's no longer responding enough with the medication. And those are, those, when you have these symptoms or combinations of these symptoms, that's when you really should be asking about and discussing advanced therapies. For essential tremor, that's a different tremor disorder. The tremor can look a little different than Parkinson's disease. Oftentimes one can be misdiagnosed as the other, especially early on in the disease, but usually over time, and depending on other symptoms, that diagnosis can become clearer. If there's doubt, that's a good reason to have a consultation with a movement disorder specialist, which really quickly is a type of neurologist. So we are subspecialists within neurology that specifically work with people who have movement disorders. And so if you are talking about advanced therapies, like you are likely either going to be referred to or are already seeing a movement disorders neurologist. Not always, but for the most part. And then dystonia. Dystonia is a very broad category as a disease. There are lots of causes for dystonia. It can be part of a disease, so you can have dystonia as part of Parkinson's disease, or you can have dystonia on its own. There can be genetic causes. It can be a consequence of exposure to certain medications. And so DBS is an option for dystonia. It's of course, a discussion like with all of these, and depending on the subtype, the responses and expectations might vary for that disorder. So advanced therapies, and I kind of alluded to this already, are therapies that are generally speaking for Parkinson's, for essential tremor, for dystonia. These are procedures that are available or that should be investigated when medication alone cannot control your symptoms. The way this works, so the brain is all about circuits and networks, and we have found that in these movement disorders, one part of that circuit is either working too much or too little. But we have found that if we manipulate one part of that network, or if we try to jam a part of that network, that we can control the symptoms. And so we can disrupt this network, this circuit in different ways. And that's, we'll talk about what those ways are. But it's important to know that it's not slowing down the disease, it's not curing it, it's not reversing it, but it's another way to control symptoms. And so that's why we usually want to make sure we've tried medication and that your medications are the best combination, that we've tried appropriate medications and doses. And if they're still not working, to then talk about advanced therapies. And this slide just shows, this is a slice of the brain, and it shows three of the targets that we most commonly use for the movement disorders. And so depending on what disorder you have and what symptoms you have, we might create, that little disruption in the network, that little either lesion or DBS in one of these structures. And so these are just terms that you might hear when we're talking about them. So subthalamic nucleus, or the thalamus, the ventral intermediate nucleus, or the globus pallidus interna. And then there are different reasons to pick these, but just know that these, if you hear these terms, these are parts of the brain that we're targeting in these procedures. We're not talking about infusion therapies in this talk. We're mostly focusing on surgical advanced therapies, but do know that there are other advanced therapies that are not necessarily oral medication, but they're different ways of delivering medication. So that's not part of our topic today, but just so you know, those are also considered advanced therapies. Now, in terms of lesion therapies, there are three different ones, if you might have read about or heard about. And those are radiofrequency ablation, gamma knife radiosurgery, and then focused ultrasound. The aim of all of them is very similar, again, is to create a little scar, a little lesion, a little disruption in that network or circuit in those specific parts of the brain. Radiofrequency ablation is used primarily for tremor. Most of these, actually, I should say, currently are used primarily for tremor. So not all the symptoms of, if you have Parkinson's disease. Mainly these are for tremor. Typically they're unilateral, which means one side, with the exception of focused ultrasound, which can be both sides, and we'll talk very briefly about that. But radiofrequency ablation has been around for some time. It has good response in terms of tremor improvement. It does involve putting a tiny, so it is a procedure, and it involves putting in a tiny sort of probe into the brain, again, that part that we want to create that lesion in, to create a lesion and control that tremor. Again, these have been around for a while. There's still centers that do radiofrequency ablation, so it's still available. Gamma knife radiosurgery is another one. It's used a lot more in oncology, so for cancers, brain cancers, and other things. It's used much less in movement disorders anymore. It's been around for some time, and it was used for a while, and it does work. This graph is mostly showing the improvement in different types of tremors, and so the difference between the light blue and the dark blue is the improvement in tremor. So there is benefit with it. It does work. It is using radiation to create a scar. It may be something that comes up in very specific cases still as an option, especially if there are other medical conditions or other issues to consider, but it is not used terribly often anymore. And some of the reasons are the benefit is delayed. So with radio frequency and ultrasound, you'll see improvement pretty quickly, immediately almost. But with gamma knife, it can take up to a year before you see any improvement. And there do tend to be some delayed side effects. This is an image of a brain, and if you can see my mouse here, but this part, oh, you can't see my mouse, but that on that right side of the screen where you see the bright white, that's a bleed, and so these are potential side effects that can happen with it. And the side effects for most of these are related to some of the other structures and fibers that are nearby, and so a lot of times it can affect strength, or it can cause tingling or numbness, or changes in speech. And so if you do have side effects, then or if you have sort of a side effect like a bleed or something like that, then those can be those are symptoms that you might experience. So this is more to know that it's out there in very specific cases. Depending on other medical issues, it may come up as an option. It is effective, but it's important to consider the risks and benefits of of getting this particular procedure. Now, MRI-guided focused ultrasound has probably replaced the other two, considerably, especially in recent years. So this is, again, another way to create a little scar in the brain, same parts of the brain that we've been, targeting with those other procedures, to help with tremor specifically. It has been used a lot. It's been used a lot more recently, but it's been around for quite some time. So it was first used in the late 50s. And the problem is that this relies on being able to be in an MRI scanner. And we use that MRI to kind of target and find the location and pinpoint the location we want to create the scar in. And then we're using ultrasound, so sound waves, to create a scar. And so a lot of times, the way I describe it to my patients is kind of, if you hold a magnifying glass up to the sun and you concentrate those beams, and you can create a little, you can create heat and cause a little burn or scar. And so this is a similar idea, roughly. But the reason it wasn't used for many, or some of the challenges over the years was getting those sound waves through the skull and your bone. But in recent years, that's been less of an issue. It is still part of the screening process, kind of looking at the density of your skull. But all that to say, it's become a lot more available and accessible in more recent years. And so it's another way to create a scar to control tremor. It's being used quite a bit for essential tremor, but it is an option for Parkinson's tremor specifically. So if you don't have a tremor, this is, at least at the moment, not an option. And typically we start with one side, and in a delayed fashion can do the other side with some caveats. It works pretty well again, and so this graph, these are just fancy ways of showing that there's an improvement in tremor. So if you focus on the graph on that right side with the colors, with the many colors, you can see how on the day of the treatment, there is this big improvement in tremor, and that seems to persist over time when we've tracked that tremor. The main side effects to be aware of, sort of the more common ones, if you will, are again that numbness, tingling. It can affect balance. So if you have balance issues, that's a discussion to have. It can affect those. Some people can get very transient weakness. Those are the big ones. But I think the main thing to focus on in this is that over time, by year 3, very few people, a very small percentage of people still have side effects. And so for the most part, these are transient side effects. But again, it's important to know the potential risks of these procedures. For those of you who have seen a movement disorders neurologist, or even a general neurologist, or even primary care, you might be familiar with these spirals. We like having you draw spirals to kind of get a sense of what your tremor looks like. And so in this image is showing the change in the spirals through the procedure of the focused ultrasound. And so you can see at the very beginning, that's before the procedure. And the third image is the improvement in tremor as the procedure is being completed. So it does work quite well for tremor. And then the other important thing to remember is that it's a sustained benefit. And so these people are followed 4 to 5 years, and you can see that there's an up to 70% improvement in tremor, and that persists over time. So it is also important to remember that it's not zero tremor. So the goal isn't that these procedures are completely eliminating your symptoms. The goal is that we're reducing them considerably. And so even with it being, 70% is pretty good, but even with that, there's a considerable, quite a bit of improvement in quality of life and the disability related to tremor over time, and that does persist over time. For Parkinson's tremor, it's also used, like I said, for Parkinson's tremor, and that is also a persistent improvement over time. It's about a 62% reduction of tremor, so a little less than essential tremor, but fairly comparable overall. So now let's talk to you about deep brain stimulation. So these are the slide is mostly to show that DBS has been around actually for a little while. So a lot of people think of it as a new procedure still, or that it's experimental or novel, but it's actually been around quite some time. It's been used in other diseases and other symptoms for a while, but even for Parkinson's disease and tremor and essential tremor and dystonia, we have decades of experience in it and decades of comparing different targets, and that technology continues to evolve drastically. Within the United States, there have been over 120,000 patients that have been implanted. The first surgery was in Europe in the late 80s, but in the US, it's been approved for essential tremor since the late 90s. For Parkinson's disease, it's, about 25 years ago, same with dystonia, and then actually it's been approved for obsessive compulsive disorder for some time as well. There are a few other indications on this list that are not movement disorders. This is a graph of how it's been, sort of the utilization of DBS, and so how many people have been getting them over the years. So you see in that top graph, that purple line above is just showing how DBS has increased over the years from the approval in 97, and this data, this information just goes up to 2017. So it's a steady increase and then probably a little bit of a plateau in the last few years. And then the other thing is the radio frequency ablation. Remember, we talked about that was the, creating that scar. And so that kind of dipped down when DBS came around. And then it's just, again, not quite zero, even though it looks like zero on this graph, but it's been pretty low and even over the years. This does not have information about the focus ultrasound just yet, but that's been an increasing use as well. And then when we break it down by disease, the majority of the interventions are for Parkinson's disease, and you can see those going up over time. And then essential tremor is the second most common use, and then it's been a steady even use over the years for some of the other indications like dystonia. So in terms of efficacy, how effective is this? When, in the studies they compared, remember those targets we talked about? So this one in particular is a subthalamic nucleus. The other target is globus pallidus interna for Parkinson's disease. And they're, with some nuance and some specifics, they're fairly comparable. We might pick one over the other depending on what your main symptoms are that you're hoping to improve. But in this original information, there was study, there was a 25% improvement in quality of life with DBS, and then a 40% improvement in the UPDRS, and that's a scale that we use to grade your Parkinson's symptoms. And so again, if you've seen a movement disorders neurologist, a lot of us will have you kind of tap your fingers and open, close your hand and walk back and forth. And so those are parts of the scale that we use. And so it's a way to give you points or give points to your symptoms. And so there's an improvement in those symptoms. And for most people, these numbers were, when they were asked, were meaningful changes. And again, like I said, goal is not zero symptoms, but better control of these symptoms. And for essential tremor, there's, about a 60 to 70, usually a little bit higher improvement in tremor, either unilaterally, so either one side or both sides. Typically, we're targeting improvement in hand tremor, and so improvement in the ability to eat and write and drink and things like that. And the quality of life improvement is pretty considerable with essential tremor as well. And for dystonia, that really depends. It's a little bit more of a detailed discussion because it really depends on the type of dystonia. Is it generalized? Is it genetic? Is it medication induced? Is it part of Parkinson's? Is it, one limb, or is it your whole body? Is it your neck? And so, 50 to 60% is a very general sort of number in terms of improvement. But that's a discussion to have with your movement disorders neurologist because it varies from depending on what type of dystonia you have. And so things that get better with DBS are tremor and for essential tremor and Parkinson's disease. For Parkinson's disease, it can reduce dyskinesia. So those are those extra movements that are a side effect of the medication. It improves the amount of on time, so the time that your symptoms are well controlled, and most people need to still be on some medication. So goal is not zero medication, but less medication. And so with the subthalamic nucleus, that one target that we talked about, there's about on average a 50% reduction in medication. So some of the side effects get better because side effects from medications improve because we're able to reduce your medication with DBS. And pretty consistently, there's an improvement in quality of life. Generally speaking, I'll say if the symptoms respond to medication like levodopa, then they'll respond to DBS with a few exceptions. And tremor is also one of those exceptions. Sometimes tremor does not respond to levodopa, but it will still respond to DBS. In essential tremor, there's, of course, the improvement in tremor, and with that comes often a reduction in medication. We can not infrequently actually come off medication as well. It is important to remember, again, like we talked about, this is not slowing down the disease or reversing it. And so it may be that initially with DBS, you have a considerable reduction in medication, whether for Parkinson's or essential tremor. But that over time, as the disease progresses, some years later, you may still need to increase or adjust medications, either for other symptoms, usually for other symptoms. With essential tremor, it might be just a little bit of reemergence of tremor that over the year sometimes requires trying medications again. Things that the DBS does not help, and this is important to remember, is that it's not going to improve speech, and these are mostly for Parkinson's disease. So it's not going to improve things like the softness of your voice or slurred speech or your swallowing issues. It is not going to improve or any type of memory issues, thinking issues, processing issues, mood issues. Any what we call non-motor symptoms, not any, but the goal should not be improvement in the non-motor symptoms. And so, excessive saliva, bladder issues, bowel issues, blood pressure issues, those are typically not going to respond to the DBS. Now, if you have blood pressure issues because of medication as a side effect, it is possible that reducing the meds will help improve that blood pressure. But that said, that should not be the goal. The goal should be improvement in your movement symptoms. And then an important one is balance. And this applies to both essential tremor and Parkinson's disease. And so if you have balance issues, regardless of the cause, those are not going to improve with DBS, and sometimes they can worsen. And so that's an important discussion to have. And then if you have freezing, if you have Parkinson's, that's not going to get better with DBS. So when we talk about DBS, it is a process, and that's part of the expectations. And it is a process because it really works well for the right candidate. And so we make sure that we're taking our time figuring out if this is the right option for you. And so we think about it in three parts. The first biggest part is, patient selection. What is your diagnosis? Is it what we call regular Parkinson's disease, or is it a different subtype of Parkinson's? Because that is an important discussion. What your age is, what your other medical issues are, what symptoms you have that bother you the most, and what you're expecting to improve with DBS. How much you respond to levodopa, that's the dopamine cinemet, because like I said, things that respond to levodopa movement-wise tend to respond to DBS, except tremor, because tremors can sometimes not respond to levodopa. And then talking about expectations, so making sure that you understand what DBS is, what will get better, what won't get better, that it is a process and not just the selection process, but the surgery itself and then the programming itself also. And then the second part is the surgery itself. And I should say, this is, I'm talking about the University of Colorado, but most movement centers will have a similar process with some minor differences for the most part in how they kind of work people up for DBS. And this is the same, relatively similar for essential tremor and dystonia. What is your clarifying the diagnosis, other medical issues, what medications have you tried or not tried, and then also expectations. The surgery itself, where you're getting it, the surgeon, the type, the nuances of surgery, and Dr. Ogerman's going to talk more about the surgery itself. And then the programming part, because it's not just about, the selection, choosing to do DBS and then just getting the surgery. There's also turning on the device. And we'll talk about what programming means in a little bit as well. But those are sort of the three parts that are part of this process that are important when you think about being successful, so to speak, for DBS. So the evaluation, of course, there's the initial, so you have to have an initial evaluation with a movement disorders neurologist. You may already be seeing them, or you may be seeing a general neurologist, or you may even be seeing your primary care doctor. But for this, typically these are done at centers that have movement disorders neurologists, and so you'll have an initial evaluation. That evaluation will be, of course, confirming the diagnosis, because there can be misdiagnoses at times, or you might have more than one disorder. So you might have both Parkinson's disease and essential tremor. And so it's important to have that initial consultation, and then also to make sure that you've tried all the available medication, not all, but that you've had an adequate trial of medications, that they're at the right doses, that we've tried all the things that we can. If it's Parkinson's disease, there will be something called off-on testing. And so that typically means you come in off your medications, not having you taken your medications. So we see what your disease looks like without medication. And your exam is recorded. And we do that UPDRS that I talked about, which is, kind of those movement tests. And we give it a number score. And then we have you take your medications in clinic. Wait for them to kick in, and then we do an exam again. And the reason for that is, again, to see how much you respond to levodopa, because that's an important part in the expectations of how much you'll respond to DBS. If you have essential tremor, typically you'll come in for, again, a grading. It's a different scale, but a similar sort of test that we do, and your exam is recorded for that as well. Everyone gets neuropsychological testing for DBS, and this is an involved memory testing of how your brain is functioning. And so it can take 2 to 3 hours. And so it's a very involved memory test, is a simple way to think about it. And the reason we do it is to understand what your cognitive functioning is like at baseline, because it helps us understand risks. You'll get an MRI, that's an image of the brain that we'll get before. Part of it is for planning, and part of it is to make sure there isn't anything else going on. You'll meet with the neurosurgeon who's going to be part of the procedure. And then there are other steps that we might have people go through depending on their specific circumstances. And so a lot of our patients will also see our neuropalliative care team. We're very fortunate to have that team here, and we'll talk about expectations and goals and things like that. Sometimes we'll have social work involved. Sometimes we'll have you see a physical therapist if there's some balance issues. And so there may be some other moving parts to this. So like I said, it is a process, but the reason it's a process is to make sure that it's the right option for you, and that will have the improvement in quality of life, which is really the goal of all of this. Here we have, like I said, most centers, there's a multidisciplinary team. And so what that means is that there are just lots of different specialists. And so, as part of the process, you'll do all of those steps and procedures, and we'll collect all of that information. And then the neurologist, the neurosurgeon, the neuropsychologist, and then whoever else may have been involved, we meet on a regular basis. We go over those scores, those recordings, your other medical issues, and decide, hey, what is that target in the brain that we want to use? And are you a good candidate or not? So it's not it's not one person making that decision. It is a team approach. And some of the things that we talk about are how that neuropsychological test showed. And so if there were more memory issues than you necessarily appreciate or recognize, that becomes part of the discussion. We want to make sure that you have good social support, because it is brain surgery. And so, whether it's Parkinson's, essential tremor, dystonia, making sure that you'll have, sort of a support system after surgery, and, keeping up with all of this, and that after meeting all these people and going through all these steps, that we're all on the same page in what we're expecting will happen and what we think our goals are. Things that are contraindications to DBS, and so, reasons that you may not be a candidate. And like I said, Dr. Baumgartner is going to talk about it in more detail, but overall, if someone has dementia, and so dementia is a general term, it really means that you have memory issues that are significant enough that it is affecting your day-to-day function, or that you're needing help with day-to-day function because of your processing. And so if someone has dementia, then DBS is not the right option for that individual. It's not going to improve it. It can worsen it. If you have early sort of drops in blood pressure or a lot of bladder issues very early on, or if you have a lot of swallowing issues early on, then you're likely not a candidate. And part of that might be is because it may not be sort of the typical Parkinson's disease. It may be an atypical disease or a different disease that is difficult to tell apart from Parkinson's disease early on. If you have other medical issues that make it very high risk for you to get general anesthesia, then that is, part of it, or any type of anesthesia. If you have a bleeding disorder, that's part of the discussion. If you have when we do that MRI, if there's a lot of shrinkage of the brain, and then also, again, I keep bringing up the expectations, but if we're not all on the same page, then that might be a reason not to go through with DBS. And so, for example, if the goal is to improve balance or memory, then that's not an appropriate reason. We're not going to be doing DBS for that. And then the other part is also mood, and mood can be, part of your disease, or it can be independent of your disease. But if you have untreated, and some of this, part of the neuropsychological testing can, bring some of this out as well. And so if you have depression or anxiety or any type of mood disorder that isn't treated well enough, then that might be a reason to hold off on DBS. It may not necessarily mean you can't get it ever, but it may be a pause. Let's treat this and reassess. Now, parts of the DBS, there are three parts. Well, generally speaking, there's the lead that goes in the brain, and that's pretty small. Those are those pictures that you see on the left there, and this is much bigger than what they actually look like. There's a wire. It's underneath the skin, and it's connected to a battery pack, or IPG, implantable pulse generator. That's the other term you'll hear us use for it. This is all underneath the skin. If you've ever seen someone with a pacemaker, that's kind of what it'll look like. Sometimes I describe DBS as a pacemaker for the brain, and so that's a good way to kind of think about it. And then that brings me to the programming part. And so, we talked about, picking DBS, being a candidate for it, going through the surgery. And then really quickly, I forgot to mention the surgery is typically 2 parts at most centers with some variations. And the first part is, putting those leads in the brain. And then the second part is usually a couple of weeks later, and it's an outpatient procedure. And that's where you come in and have that battery put in, and it's all connected. Now, it's important to note that after that, it's still off. This device is off at that time, and this is where the programming comes in. And so once you have your surgery dates, usually you'll work with a DBS coordinator or a program manager. For us, it's Mari. She'll be giving that last talk in the webinar, who'll help coordinate the visits, the programming visits. So we wait a few weeks after the leads are put in, just for you to recover, for that swelling to go down. And this applies for all of, Parkinson's, essential tremor, dystonia. And then we'll set up programming appointments. That first appointment's typically a pretty long one. At our center, we have you come in not taking medications for that first appointment. And that's when we turn on the device. We check each of those little parts of the device, each level on it, and try different settings and try to figure out what your initial setting is going to be. And then we have typically every 2 to 3 weeks apart another few visits, and that's to fine tune it. And sometimes we'll reduce medication at the same time as we bump up the simulation. Sometimes we'll do one first and then the other. And so it really depends on you as the individual. When I talk about programming, so these are the tips of the leads here. And so these blue marks are tiny little what we call contacts on the leads. And so remember, I talked about the brain as being a circuit and a network. And so these little tiny contacts are the important parts. Those are in the part of the brain that we are targeting. And so in that first programming session, we will turn on each contact and we'll slowly move up those. And depending on the device, there's different ways. Sometimes we'll use more information, so we'll use your imaging, we'll use that LFP that we talked about. Dr. Thompson's going to talk about it to kind of figure out which is the best contact for you to turn on that's going to control your symptoms the best. Some symptoms respond immediately and some are a little delayed. And so when I talk about turning it on, I mean so there's little tiny pulses of electricity that are being generated, and we can control how long each pulse is, how frequently it's firing, and what the intensity of it is. And then we can also control the shape of the field, so to speak. So it could be like a little sphere, we can move it around because within those structures, we might want to stimulate different areas. And so that's what the programming is about. It's kind of figuring out the right spot to stimulate that's going to control your symptoms the best. And then there are 3 different companies right now that provide DBS. Each of them has different, they have different sort of nuances to them. Some of them have that LFP that we talked about. Some of them let us integrate your imaging. Some of us let us program remotely. Generally, they're somewhat similar. And this is a decision that you make along with your surgeon and usually your movement disorder neurologist as to which device is the right one for you or the right pick for you. The companies are Medtronic, Abbott, and Boston Scientific. So those are sort of the 3 big companies. And usually you'll have, so on the screen, these are pictures of them. And so the smaller devices are programmers that you will have with you. And so these programmers might let you they will let you turn the device off and on. Sometimes you might need to turn it off for some particular reason, or, sometimes people with essential tremor might turn it off at night. And but also all of these might let us give you the ability to change your setting. And so, not always, depends again on your symptoms and your neurologist, but we might give you the ability to either increase settings, decrease settings, try a different combination, a different program for settings. And so the programmer that you have lets you do that switching and toggling. And then we're okay on time, so this is my last slide here, and this is side effects. This is important. So the side effects are low, they're fairly low, and they can vary a little bit by center. Some more experienced centers are going to typically have, on the lower end of these side effects, but it's important to remember these are not 0. And everyone is different in terms of what they think is acceptable risk. And so, for some people, any risk of these side effects is just not worth it for them. And that's this is your decision to make. Our job is to make sure you know what they are. And so, we are putting something in the brain. So there's always the risk that there might be a bleed or a stroke with that. This is an implantable device, so there's the risk for infection. For some of them, there might be, you might have more procedures over time, and that's to replace the battery. And so a lot of them have a rechargeable battery. You can recharge them externally. And so those can last many, many years, depending, before they need to be replaced. But some people don't want to bother with having to recharge it or remembering to recharge it, or their lifestyle may not allow for it. And so those batteries might need to be replaced every 3 to 5 years. And that's typically an outpatient procedure, but that is something to bear in mind. And then some of these other side effects can be depending on the setting and depending on how quickly medication were adjusted and whether you had, if you had mood issues beforehand or if your meds were reduced too much for Parkinson's specifically. And again, that memory part of things. And so that word finding issue can sometimes get a little worse. Processing speed can change. And so that's why we get that neuropsych testing, because if we know how you're doing at baseline, it helps us predict a little bit, not how much you might respond to the DBS itself. So that was a lot of information in a short amount of time, but the goal is to give you guys an overview, and I think we can open it up for questions now.